Hello, thank you so much for inviting me to be part of the conference today. I'm just really sorry that I'm unable to be there in person, but hope that this presentation will go some way to try and answer the questions that you have regarding the genetics of hyperinsulinism. So I think what has become really clear to the team in Exeter, leading over the past few months and also leading up to this conference, is that actually we're not doing a very good job at providing information to families regarding the genetics of hyperinsulinism and providing this in a format which is accessible to all. So based on this, we are plan to do big update of our website, providing much more information about genetics and the genetic subforms of hyperinsulinism. But importantly, we're also developing patient information sheets for each genetic form of HI, which can then be downloaded by families who can get a really good overview of that genetic subform of hyperinsulinism. What became clear is that there's also a huge gap in people's knowledge about inheritance of genetic variants and the risk of passing on a genetic variant to future children within the family, and that individual's risk then of developing HI. And this became really clear, specifically when I got given the list of questions for this conference, with over 60% of the questions relating to inheritance and recurrence risk within families. So I'm really, really sorry, but I'm unable to answer each of these questions within this forum, specifically because every single family within the room is going to have their own unique set of genetic results. And actually, the genetic findings in each family are often quite complex and difficult to interpret without a genetic report in front of you. So what I would really not want to do is provide any advice to families without having a copy of their genetic report in front of me and knowing exactly what has been found within that individual family. This also really highlights the fact that families do need bespoke advice for the recurrence risk within that family, and that actually that advice needs to come at a time where it's most appropriate. So, for example, what we know is that advice on how you manage pregnancies in hyperinsulinism is likely to change over time as new technology and knowledge of the disease improves. So therefore, if you receive advice now, it may be different to the advice that you would receive in 15 or 20 years' time when your children are considering starting their own families. So in order to try and help address this gap, as I said, we're going to develop a patient information sheet which provides an overview of the genetics of inheritance of variants within hyperinsulinism genes, but actually really focuses on the fact that each family needs to get tailored advice, and that this really should be coming from your local clinical genetic service, who you'll be able to have an appointment with and sit down and discuss all sort of aspects of inheritance of the variant and likelihood of recurrence of HI within your family. Within that patient information sheet, we'll also provide guidance as to how you can go about getting an appointment with a genetic counsellor. But essentially, it would be either through working with your teams who are managing your HI, so at Manchester or Alderhay or Great Ormond Street Hospital, so speaking to your consultant, or you can also get an appointment if you speak to your local GP. So one of the questions which I can answer is this question, which has come from a family who have negative genetics. So they've had screening of the known HI genes, hopefully, but no variants of significance have been identified. And their question is whether or not another genetic abnormality could be responsible for the HI in their family. And they've given the suggestion that could this be as a result of an issue with calcium signaling. So by way of some background, we have in Exeter, we've received samples from over 5,000 children with hyperinsulinism for genetic testing, and around 35 to 40% of those do not have a genetic diagnosis following routine screening. We know that many of those are likely to have a genetic form of hyperinsulinism, that we just haven't been able to pinpoint what the exact genetic variant which is causing the HI in those families. But we are actively doing research to try and find new genes for hyperinsulinism. And in the past 12 months alone, we've had quite a few new discoveries which have allowed over 100 people with a historic diagnosis of hyperinsulinism to receive a new genetic diagnosis. So really, this is just to highlight that, yes, it is possible that you have a genetic form of hyperinsulinism, and we are actively working on samples from similar families, or maybe even your own family, where we are trying to find new genes for this condition. And as soon as we find anything, we'll be in contact with your clinical team who'll be able to relay these results to you. It's also a really good suggestion regarding the calcium issues. And yes, this is definitely a pathway that we are interested in, as we know that calcium signaling is really important in insulin secretion. Okay, so the next question has come from a family who are interested to learn more about exercise-induced hyperinsulinism. So this is a relatively rare form of HI, where people who often do anaerobic exercise, then get severe hypoglycemia about 20 minutes following that exercise. So they're interested to know whether there are any trials that they can get involved in, and what do we know about the inheritance of this condition. So over the past 24 months, this has been an area that we've been really interested in, and we've actually made quite a lot of progress in our understanding of the genetics of this condition. So we've now detected the genetic cause of exercise-induced hyperinsulinism in over 40 families within our cohort. And these families have a variant in a gene called SLC16A1. In all of these families, the variants are dominantly acting, which means that the variant has come from a parent who also has exercise-induced hyperinsulinism. So we know that there are other families within our cohort who also have exercise-induced hyperinsulinism, where we still haven't found the cause of their HI yet. And these are families where we are actively trying to find new genetic causes of this condition. SLC16A1 HI is one, because we've had quite a lot of research interest in this form of HI over the past 24 months. This is one of the first patient information sheets that we've put together, and this QR code will give you a link to this genetic form of HI's patient information sheet, which you can then download from our website. And this also tells you about some of the studies that we're doing to try and improve our knowledge about this form of hyperinsulinism. So if you are interested in taking part in any of these studies, please feel free to contact the team at Exeter. Okay, so the next question, which has been put forward, is regarding research which is being undertaken into another rare genetic form of hyperinsulinism, which affects the calcium channel gene, which is referred to as the CACNA1D gene. So again, this is an extremely rare form of hyperinsulinism. I think we only are aware of 8 children in the world who have this form of HI. And at the moment, there is some research being undertaken at Great Ormond Street Hospital by Antonia Dastamani and her team, who are looking at the role of a drug called nifedipine to see whether it can improve neurological outcomes in children with this form of HI. And that work has recently been presented at the European Society of Paediatric Endocrinology meeting in Denmark. We recognise that this is a genetic form of HI where families are going to really, really struggle to get any information at all about this condition, and therefore this is one of the genetic subforms that we have prioritised for making a patient information sheet. So this patient information sheet is now live, has been uploaded to our website, and this is a link, so please feel free to use the QR code and download the patient information sheet, which gives you an overview of what we know about this form of HI. So the next question relates to whether or not we know if the genetic type of HI can put you more at risk of ADHD or autism. Again, this is another really, really timely question, and this is something that we are really interested in studying in Exeter. And we're very lucky that we have Dr. Pam Bowman in our team, who's a clinical geneticist with expertise in neurodevelopmental disorders and paediatric endocrinology. So what Pam has done over the past few months is to contact the team at CHI and access data from their global registry, which is self-reported data from families, which looks at, has gathered information onto different, whether or not autism or ADHD is reported in children who are within the registry. And what we found so far, data still needs cleaning, it's still very preliminary, is we've taken some of the most common genetic forms of hyperinsulinism, and we can see that across those genetic forms of HI, that there are multiple neurodevelopmental concerns in all children, regardless of the genetic subtype of HI. What we really want to do now is dive deeper into this data to see whether or not there's specific patterns related to different genetic subtypes of HI. So, for example, you can see here that this blue bar represents children with GLUD1 HI. So these children, there seems to be a higher proportion of these children with epilepsy, and also a higher proportion of these children who have developmental delays. So again, preliminary data, but just to really flag to you that this is something that we are also really interested in and something that we are actively researching. So the final question relates to the generation study. So this is an initiative by Genomics England, which is part of the NHS, where they are screening healthy newborn children for 200 plus genetic conditions at birth. One of those conditions is congenital hyperinsulinism, and it's just a very, very quick update to let you know that so far we're not aware of any cases of hyperinsulinism that have been detected through this study to date. So I will leave it there. Hopefully I've answered all the questions that I can, and hopefully you will all be able to get more information soon through our website and patient information sheets. Thank you again for inviting me to take part in the conference, and I hope to see you all again soon. Thanks very much.